Good evening. Welcome to our Community Pathways Proposed Medicaid Waiver Amendment Stakeholder Engagement webinar. We're going to get started at 6:05. We want to give all attendees a chance to log in. Welcome to our Community Pathways Proposed Medicaid Waiver Amendment Stakeholder Engagement webinar. We're going to get started at 6:05. We're going to give all of our attendees a chance to log in. Welcome to our Community Pathways Proposed Medicaid Waiver Amendment Stakeholder Engagement webinar. We will get started at 6:05. We're going to give all of our attendees a chance to log in. Welcome to our Community Pathways Proposed Medicaid Waiver Amendment Stakeholder Engagement webinar. We will get started at 6:05. We're going to give all of our attendees a chance to log in. Welcome to our Community Pathways Proposed Medicaid Waiver Amendment Stakeholder Engagement webinar. We will get started at 6:05. We want to give all attendees a chance to log in. Good evening. Today is Wednesday, March the 11th, 2026. I am Eric Feaster, Professional Development Coordinator for Maryland Department of Health's Developmental Disabilities Administration. We welcome you to our Community Pathways Proposed Medicaid Waiver Amendment Stakeholder Engagement webinar. If you would like to use closed captioning so you can read what is being said, click this button. Sometimes the transcription is not exact, but it is pretty close. All attendees are currently in listen-only mode and your mics and cameras are turned off. Today's presentation is available in the handout section. Click here where you see the paperclip to download the presentation. If you have a question you would like us to read and answer, click here where you see the question mark to add your question. If you would like to ask a question aloud during our comments section, please click this button to raise your hand. We will invite you to unmute during our public comment section of today's presentation. Before beginning our meeting, we also want to ensure civility for all meetings. The free expression of diverse viewpoints is a fundamental value of our group. This freedom carries the responsibility to engage respectfully, which means treating one another with dignity and respect and good faith. Uncivil behavior, disruptive conduct, abusive language, threats, or harassment will not be tolerated and may lead to being excused from the meeting. Thank you for helping us keep this a productive and comfortable meeting for everyone. And now I'd like to turn it over to our Director of Federal Programs, Rhonda Workman.
Thank you, Eric. Good evening, everyone. My name is Rhonda Workman. I'm the Director of Federal Programs. Thank you again for taking the time to join us today. We really appreciate your interest, your partnership, and your willingness to engage in this important conversation that we're having tonight. Tonight's presentation is the exact presentation from midday today that we shared. It will focus on the proposed updates to the Community Pathways Waiver. Our goal is to clearly explain what is being proposed, why changes are being considered, and how this may impact people and providers. Most importantly, we're here to listen. Your feedback matters. We are actively seeking ideals, concerns, and alternative strategies to help ensure the long-term sustainability of the program while continuing to support people to live, work, and thrive in their communities. All comments and input shared during this process will be carefully reviewed and considered before any final decisions are made and before the amendment is submitted to the Center for Medicare and Medicaid Services. We are committed to transparency, collaboration, and person-centered values throughout this process. Thank you again for being here and for being part of this work. Next slide, please. Can you go to the next slide too? This slide is an overview of our agenda today. It includes an overview of what a Medicaid waiver amendment is. We'll also share some information related to our program sustainability, and we will go through our amendment proposal and provide additional information on the public comment process and resources. I am now going to turn it over to Don Rudolph, DDA's Deputy Director for Federal Programs, to share an overview of the Medicaid waiver amendment. Next slide, please.
Thank you, Rhonda, and thank you, Eric, for facilitating us, and thank you, everyone who's joined the call. This is Dawn Rudolph. I'm very pleased to be with you today. If we could go to, actually, before I get to the next slide, I do want to just mention that this section of our presentation today is going to talk about what a Medicaid amendment is, a Medicaid waiver amendment, so you get oriented to the overall idea before Rhonda digs back into the specific details in a little bit. If we could go to the next slide. So a Medicaid waiver amendment is a request to the Federal Centers for Medicare and Medicaid Services, which is CMS, a request to make changes to a Medicaid waiver program. Our Medicaid waiver program is the Community Pathways Medicaid waiver program is what DDA operates, and it has already been approved by CMS. So if we make changes to it, then we need to ask CMS to approve those changes. And before we do that, we want your input, and we want to make sure that your thoughts and ideas are incorporated. So this is our opportunity to review the waiver amendment that has been drafted and to provide you with the opportunity to give public input. On the next slide, please. So this slide provides an overview of the structure of Medicaid waiver program applications. All of them are organized, all of the kind that we have, the 1915C waiver, are all organized in the same way. Each application includes specific appendices, like chapters in a book, that contain required information and/or options for states to consider. For amendments like this there is an amendments request appendix. This provides an overview of the purpose of the amendment and will include a summary of the public input received so that CMS will also get a sense of the input that you share. Appendix A is the waiver administration and operations section, which outlines the state's responsibilities for managing and overseeing the waiver program. It details the roles of different state agencies and how they ensure compliance with federal Medicaid requirements. Appendix B addresses participant access and eligibility. This outlines the state's responsibilities for determining participant eligibility and ensuring equitable access to waiver services. Appendix C addresses participant services, and this outlines the state's responsibilities regarding participant services and service planning. It describes the types of services available in the waiver, the criteria for those services, and how they are delivered to meet participants' needs. Appendix D is the participant-centered planning and service delivery section, which outlines the state's responsibilities for ensuring that waiver participants receive services based on a person-centered planning process. And this process ensures that individuals have a say in their care and receive services that are tailored to their needs, their goals, and their preferences. Appendix E addresses participant direction of services. And so this outlines the state's responsibilities when waiver participants are given the option to self-direct their services. Appendix F addresses participant rights. This appendix outlines the state's responsibilities to ensure that participants' rights are protected and that they are safeguarded from abuse and neglect and exploitation. Appendix D is participant safeguards, which outlines the state's responsibilities for ensuring participant safety and service continuity during emergencies, disasters, and other disruptions. Appendix H addresses systems improvement, which outlines how the state ensures compliance with federal requirements, monitors service delivery, and improves the quality of services for waiver participants. The state must implement a quality improvement strategy to monitor and enhance the services provided. Appendix I addresses financial accountability, and this section outlines the financial accountability responsibilities of the state. It details how the state ensures proper financial management and discusses rate-setting methodologies, billing and payment procedures, and financial safeguards. Appendix J addresses cost neutrality demonstration, and this outlines how the state demonstrates that the waiver is cost neutral during each year. The state must ensure that the waiver does not cost more than institutional care over the life of the program. Now, this Community Pathways Waiver Amendment that we're talking about today is very specific to Appendix D. We're addressing participant access and eligibility only with this proposed amendment. And so on the slide, that's why this is bolded and noted in blue on the slide that is in front of us. We have tracked changes in the waiver amendment proposal that's available to view so that the proposed changes are clearly identified from the current approved waiver to what is being proposed to be amended or changed. And we will provide some additional information later in this presentation on how and where to access that proposal and that information. So now I'd like to turn it back over to Rhonda to share information regarding program sustainability. Next slide, please.
Thank you, Dawn. As Dawn mentioned, we wanted to share some information related to the budget bill items that require the waiver amendment. Next slide, please. Current fiscal year 2027 budget bill for the Developmental Disabilities Administration requires us to implement an individual person-centered plan authorization cap of $500,000 and also to implement an exception process to safeguard health and safety. Our proposed waiver amendment includes applying a $500,000 person-centered plan budget authorization cap and the creation of a budget cap exception process that it supports health and safety within the waiver service limitations. Next slide, please. We're going to review some of the amendment proposals, but before doing so, we'd like to share some information related to input we have already received and actions we have taken. Next slide, please. We received input and concerns related to putting a cap on the exception process of up to $625,000. We also received input related to concerns on language related to discharge planning. What we have done is we have removed the cap on the budget exception process, that $625,000, and also removed the language related to discharge planning. Next slide, please. We're now going to review the amendment proposals. We're seeking your comments to include alternative proposals or strategies to address. Our goals include to support participants, comply with sustainability requirements we just reviewed, and to meet the federal assurances to be cost neutral so as not to risk losing our federal funds. Next slide, please. As Dawn had shared in the overview of the amendment request includes the purpose of the amendment. It notes that the purpose of the amendment is to establish a $500,000 annual budget limit or cap for person-centered plans, and also to create a budget cap exception process for plans that exceed the $500,000 cap. Next slide, please. Let's now review the proposed updates for Appendix B, Participant Access and Eligibility. As Dawn mentioned, this appendix outlines the state's responsibility for determining participants' eligibility and ensuring equitable access to waiver services. Next slide, please. In terms of the individual cost limit that's noted in Appendix B, the proposed amendment is to implement the $500,000 person-centered plan individual cost limit. This is a sustainability proposal and is noted in the DDA budget. Federal rules require that a Medicaid waiver program must be cost neutral. This means the waiver cannot cost more, on average, than it would cost to provide care to the same individuals in an institution for people with intellectual and developmental disabilities. Examples of state-operated institutions for people with intellectual and developmental disabilities is the Holly Center and Potomac Center. For the Community Pathways Waiver Year 4, the cost neutrality limit is $223,364 per participant per year on average. This means that, on average, the total annual cost of all services provided under the Community Pathways Waiver cannot exceed the $223,364 per person when compared to the cost of institutional care. Next slide, please. A budget cap exception process will apply to plans that support the individual's health and safety, that stays within the service limitation and exceeds that $500,000 cap. An exception process is also included in the sustainability proposal, which is noted in the DDA budget. Next slide, please. To qualify for a budget exception, the plan must meet at least one of the following standards. First, for behavioral needs, the participant has a behavior support plan and supporting documentation demonstrating the need for one-to-one or two-to-one staff to participant supports necessary to support the person with specific behavioral needs. This standard is to support standardized process and supporting documentation to support people with behavioral needs. For health needs, the participant will need to have a nursing care plan and supporting documentation demonstrating the need for one-on-one or two-to-one supports necessary to support the person with specific health and safety needs. This standard is to support standardized process and support documentation to support people with specific health and safety needs. Next slide, please. The third standard relates to a process to include consideration of the geographical rate differential. So the difference between the standard and geographical rate, if it results in the plan exceeding the budget cap, that would qualify for the budget cap exception. Finally, the state will adjust the $500,000 budget cap each year based on applicable annual rate changes. Next slide, please. In terms of supporting documentation to demonstrate the assessed need should be submitted with the nursing care plan and behavior support plan. This may include formal health, communication, or behavioral assessments completed by qualified professionals, such as physicians, mental health professionals, behavioral specialists, special educators, and other licensed professionals as appropriate. Next slide, please. A general statement or prescription that simply indicates the needs for enhanced rate, overnight supports, or one-to-one or two-to-one staffing is not sufficient. Supporting documentation must clearly describe the individual's specific assessed needs, the functional task and supports required, the circumstance under which additional staffing is necessary, and the level of staff training or expertise needed to safely provide supports. Next slide, please. The team must also consider alternative strategies before requesting an enhanced rate, overnight supports, or one-on-one or two-to-one staffing, including the use of assistive technology or remote supports technology. Next slide, please. We'd now like to share some information related to resources for the amendment proposal. Next slide, please. DDA has created a dedicated web page for the Community Pathways Amendment. On this slide, we've included the link to the page. It includes detailed information about the proposed changes. Track change documents are available so readers can clearly see what changes are included in the amendment. These documents are provided in both color and black and white versions to support accessibility, including compatibility with screen readers. We have also recently added easy read documents related to the amendment. These are provided in both English and Spanish. We have also added a frequently asked document based on our webinar last week. This frequently asked question document is available on the website in both English and Spanish. Next slide, please. Hard copies of the proposal is available for public review and comment. Individuals may request a copy by emailing our dedicated input email account, wfb.dda@maryland.gov. You can also call the DDA, any of our regional offices or the headquarters, or by visiting a DDA regional office or the Department of Health headquarters. Individuals may also ask their coordinators of community services or service providers for help in getting a hard copy. Next slide, please. This slide shows our webinars. So we are conducting the webinar on March 11th, 6 to 7:30 now. In addition, we'll have another webinar on Wednesday, April 8th from 12 to 1:30. Next slide, please. We have also created additional opportunities for input for our Spanish-speaking partners. And so we've created webinars. We've conducted one today from 3 to 4:30. Next week, on Wednesday, March 18th, we'll conduct another one from 12 to 1:30. Next slide, please. Also next week, on Wednesday, we'll conduct another webinar for our Spanish speaking from 6 to 7:30. And then we will also conduct our last one on April 8th from 3 to 4:30. Registration links are available on these slides. In addition to this information is posted on the dedicated amendment webpage. Next slide, please. Now let's review information related to the public comment process. Next slide, please. This slide includes information regarding the public comment period and next steps. The official public comment period is from March 2nd, 2026 through April 1st, 2026. The amendment will be sent to the Center for Medicare and Medicaid Services in April. The Center for Medicare and Medicaid Services has 90 days to review the proposals. The proposed amendment effective date is for July 1st of 2026. Next slide, please. Public comment can be submitted to that dedicated email address, wfb.dda@maryland.gov, or mailed directly to the DDA Federal Programs Unit at 201 West Preston Street, 4th floor, Baltimore, Maryland, 21201. It's important to note, to be considered, all public comments must be submitted by 11:59 p.m. on April 1st, 2026. Next slide, please. Can you click one more time for me, Eric? Thank you. We're now going to open up the call for questions and public comment. If you're interested in making a comment, please raise your hand if you'd like to speak, and we will call on you. Each person will have 2 minutes to share their comment. It's important to note that to ensure confidentiality, if you have a question specific to an application, eligibility, or services, that you please contact the DDA regional office. We want to ensure that during our public comment process that we are very sensitive to confidential matters and confidential information. So please, as you're sharing information or comments, please be aware of the information you're sharing and careful with the confidentiality. Next slide, please. Eric, going to turn it back over to you to help us facilitate the comments.
Okay, our first person is Tracy Farron. You have 2 minutes for your comment, and we will unmute your mic.
Good evening, Tracy. Are you able to share your comment?
Can you hear me?
Yes, thank you for joining us tonight.
Great. Thanks so much for having me this evening. I was just wondering if you could really walk us through. I'm struggling to figure out this cost neutrality, and I've been looking for the documentation publicly, and kind of, some contradictory stuff about what Holly Center and Potomac costs are, not really looking like the $217,000 that you quoted, Rhonda. So I would just greatly appreciate it if you could kind of walk us through that analysis and where that number comes from.
Sure, absolutely. So I'm going to,
Thank you.
yeah, absolutely. I'm going to share some information, but first let me share where there's some additional information you can look at. So as Don shared in our overview of the waiver amendment, Appendix J relates to cost neutrality. So if you go to our Community Pathways approved waiver, you can review Appendix J, which will give you a lot of details related to the cost neutrality calculation, and it'll give you the calculations for the remaining of this waiver program approval period. In addition, in our frequently asked questions, we also added information related to cost neutrality, where you could find it, what it means, and we've also went into details related to the different factors that are considered. So the important thing to note is that as per CMS, the Center for Medicare and Medicaid Services requirements, when states determine their cost neutrality calculation, it is based on the associated institution. Because remember, a Medicaid waiver program is provided as a option to get services in the community instead of receiving Medicaid services in an institution. For the Community Pathways waiver, which supports individuals with intellectual and developmental disabilities, our institutional level of care is referred to as an intermediate care facility for individuals with intellectual and developmental disabilities, or an ICF-IID. In Maryland, our intermediate care facilities are known as the Holly Center and the Potomac Center. And so what we have done is in our last amendment, we asked the University of Maryland, Baltimore County, to assist us in evaluating our actual Medicaid costs, the actual Medicaid expenditures associated with the Holly Center and Potomac Center. Based on that, as per federal requirements, they were able to share updated information related to the actual Medicaid expenditures on average for participants. That's what was reflected in our last amendment. In our frequently asked questions, we share information related to the different components, and we also share how we calculated for the remaining years in our program. For example, the federal government provides guidance that costs can be increased by 3% each year based on the change in the Consumer Price Index for medical care in the Mid-Atlantic region. So it gets a little bit detailed and specific, but if you look at our Appendix J, you will see a whole bunch of information related to cost neutrality and the projections. If you look at our frequently asked questions that we posted today, we have also provided additional information related to cost neutrality and the specific factors that are required within a Medicaid waiver program application. Lastly, I would say, based on the questions we have received last week and today, it's important to note that the costs that are considered are actual Medicaid expenditures for participants that are in the Holly Center or the Potomac Center, and it does not include any state funding that may have been provided to support participants or residents in the community for other community type activities. The actual Medicaid claims that are considered are Medicaid claims. And we compared the Medicaid claims within the Holly Center and the Potomac Center, and that's compared against the Medicaid claims for participants in the Community Pathways Waiver Program. I know that's a lot of information, but I hope that that's helpful with some other resources that you can look at. And we really appreciate you joining us tonight and sharing your question. Eric, I'll turn it back to you for the next question.
Our next person is Barbara Barrett. You have 2 minutes for your comment, and we will unmute your mic.
Good evening, Barbara. Are you able to hear us?
I am now, and my mic just unmuted. So thank you.
Excellent. Thank you.
My question is related to the requirements for exceptions based on nursing care plans. And I have a family member who is receiving residential care. I myself am a registered nurse with over 50 years experience and have managed my family members' very complicated nursing care for most of his life. And my concern is that that care plan that is in place for him, I am assuming now, has never been shared with family, nor have the family that managed him for all his life ever been asked to participate in creating that. And I see many things that were I the registered nurse evaluating somebody who was not my child would be concerned about. And so I'm wondering, how does that nursing care plan get evaluated in terms of its appropriateness?
Yeah, thank you for sharing that. A couple things that I would share with you is that as a person-centered system, we absolutely support the voice of participants, and participants choose who to be involved in their planning and discussions and development, not only of their plan, but they can also share with their team if they would like other team members, including family members, to be part of the development of a nursing care plan or other things. Nursing care plans would be developed by a registered nurse that must complete required training from the DDA related to nursing support services, case management, and delegation that are available under the DDA operated Medicaid waiver program known as Community Pathways. Those plans are being developed, and then they are shared and submitted with the person-centered plan, and we review those to determine the assessed need for services. And they are reviewed in our regional offices to include our regional office nurses. So I think if you have some questions or concerns, please, you can coordinate with your family member if they'd like support or to have that information shared with you, and then coordinating with the team. Thank you so much for joining us today. We appreciate it. Eric, can we go to the next person?
Yes, our next person is Jessica Gallatin. You have 2 minutes, and we will unmute your mic.
Hello, can you hear me?
Yes. Good evening, Jessica. Thank you for joining us again tonight.
Hi. Yeah, sorry. I'm joining again because I'm just a little bit confused. I wanted to be able to ask a couple of more questions. Earlier today, it was shared that patients at Holly and Potomac are often receiving services outside of Holly and Potomac. And because those services are not Medicaid claims, they're not being calculated in cost neutrality. And then it was shared that because they are getting those services funded through other means, that's what kind of like lowered that benchmark. And then I think you said that they were being funded by state-only funds because somebody had asked how they're being paid for, which is very confusing and hard for me to comprehend because that dramatically lowers the the bar, the benchmark for cost neutrality. And so it's incredibly concerning given all of the cost containment actions and the driving justification for all of this. So I was hoping that maybe you could clarify a little bit more, if do institutional costs and do those services, like if somebody goes to one of those institutions, are they not afforded some degree of a day service within that institution, some kind of a meaningful day activity or a habilitative service of some sort? Why would they need to go outside of that facility to get those services? Because then it's really not encompassing the full array of care that someone needs if it's not included. So I'm just curious. And then I'm also curious, is that what the legislators meant by transitioning those individuals using state-only funds onto a waiver so that we could be leveraging the federal match? And then to just double down on that, what exactly is the state's plan or DDA's plan to deal with cost neutrality if in fact there are no people served in institutions, which is the ultimate goal? So, what kind of methodology can be used? And if there is a route to that, why aren't we pursuing it? Sorry, I know it's like a multi-factored question.
Sure. I will try to do my best to answer your questions. A few things to note that similar to people who may be residing at a nursing facility, residents of the Holly Center and Potomac Center can leave the center and go out and engage in activities in the day. Individuals in a nursing facility can also do that. So people are not required to stay within the center during the day if that is a choice that they would make. The funding difference is that the Medicaid state plan services for which cost neutrality is based are the Medicaid expenditures paid for with Medicaid dollars for services and supports at the Holly Center and Potomac Center. If an individual is leaving during the day and engaging in some other type of day activity that may be funded with 100% general state funds, those funds cannot be included in the calculation for cost neutrality for Holly Center and Potomac Center because they are not Medicaid expenditures. You also asked a question about, let me see, the institutional cost related to day services. So I think I answered that. Please note that as I shared in I think the first question, is the state asked the University of Maryland, Baltimore County to assist us in reviewing actual Medicaid claims for our institutions so that we could ensure that we are in compliance with the federal requirements. Based on that, that's where the recalculation of cost neutrality was shared in our previous amendment, and we'll continue to watch and monitor that because we want to continue to sustain our programs and stay within the federal requirements. At this time, individuals have the choice to receive their services in the community or in the institution, such as Holly Center and Potomac Center. The DDA supports community services and will support all individuals in Holly Center and Potomac Center that choose to receive their services, all their services in the community. We will absolutely help them with that transition process to the community. But we do have individuals and families that have chosen to receive institutional services in the Holly Center and Potomac Center. So at this time, we continue to have those institutions and we'll use those as our cost neutrality factor. And if in the event in the future, we no longer have those institutions, we would consult with the Center for Medicare and Medicaid Services on what options and opportunities would be at that time. Thank you again for joining us today and this evening. We really appreciate it. Eric, can we go to the next question?
At this time, we do not have any raised hands.
Okay, great. We want to encourage everyone on the phone to share their thoughts. We're happy to take you off mute and listen to any suggestions and comments and questions. Eric, I think we had a couple hands raised.
Next person is Bernadette Oline. You have 2 minutes and we will unmute your mic.
Bernadette, is your mic open?
We have you unmuted on our end, Bernadette. So just click on the microphone.
So Bernadette, on your screen, if you're joining us on your computer, there may be a banner that has a microphone, and underneath it, it'll say MIC for mic. If it has a line through it, you just need to click on that microphone and it will open your mic on your end.
Looks like she may have withdrew her question. Oh. Let's see. We'll try and come back to Bernadette. It looks like the next person up is Karen Smith. You have 2 minutes and we will unmute your mic.
Hi, yes, can you hear me?
Yes, good evening, Karen.
Yes, my question is regarding the rate. I noticed when I was looking at some of the charts, it seems as though the rate for each of the services has increased significantly from 2018 to 2020-25. And in some cases, there was a rate increase more than one in a year, which that rate then causes individuals' budgets to be significantly increased. And so now we are looking at capping individuals' budgets. So I just want to know if you can walk through a little bit about how these rate increases occurred each year, why there was more than one per year. I know there hasn't been a COLA increase in the self-direction community for a year or two. And so I just was curious why these rate increases occurred, and more than 1 year, and why we've got these rates as high as they are.
Sure, absolutely. Thank you for sharing that. I will share a summary related to that. Rate increases for DDA funded services have increased over time. They increase based on the General Assembly's approval of the budget that includes at times a cost of living adjustment, also referred to as a COLA. During the public health emergency, during the COVID pandemic, there were also a variety of federal funding and grants that were shared with states. That includes the American Rescue Plan. For Maryland's funding that we received, legislation was passed that directed the funding that we received for our programs, the majority of it to be used for rate increases for providers. It's important to note that both service delivery model person-centered plans are included in the DDA's technology system, or the state system, known as LTSS Maryland. We currently utilize the same rates that may have had that increase or cost of living increase in our calculations of the person-centered plan authorization funding. So to summarize again, rate increases happen because they're approved within the DDA budget from the General Assembly. We also had rate increases during the public health emergency as federal funds were being pushed out to various states. And within Maryland, legislation was passed for our programs to support rate increases for our providers. And in a couple years, there were multiple rate increases, potentially because of the public health emergency, because it was a cost of living adjustment, and some of them were advanced earlier. So that's why the rates have increased over time. Thank you, Karen, for joining us and asking your question. Eric, can we go to the next person?
Yes, the next person is Krista Ennis. You have 2 minutes for your comment, and we will unmute your mic.
Hi, can you hear me now?
Yes, good evening.
Okay, great. I'm still trying to understand why the benchmark for institutional cost has dramatically reduced over these years. It doesn't make sense to me.
Sure. So let me try to share more information. Again, there's information in Appendix J, and we also have some information in the frequently asked questions. But I would also add that when we do waiver amendments or renewals, we had been utilizing the past projections and applying that consumer price index as per the guidance. During our last amendment, we reassessed the actual Medicaid paid claims, working with the university to actually look at the Medicaid claims to reset to make sure we are in line with the federal requirements to base our cost neutrality based on actual Medicaid claims. So in a sense, we reset in our last amendment, and then for year 4 and 5, as per the guidance, we applied the consumer price index. We will continue to monitor our cost neutrality, including actual Medicaid expenditures for residents in the Holly Center and Potomac Center, and make updates and adjustments within the future amendments or renewal process. Thank you for joining us today. I hope that was helpful. Eric, we can go to the next question.
Our next person is Cody Stevens. You have 2 minutes for your comment, and we will unmute your mic.
Okay, can you hear me okay?
Yes, good evening, Cody.
Good evening. Thanks for taking my hand. I just wanted to follow up regarding a question. I didn't think about it, but following up on Karen's question, we're talking about the cost of living adjustments, and we understand that there was a grant that came from the federal government that helped with providers. I was just kind of wondering, I guess, what kind of helped decide what was the decision making regarding, I guess, that money going specifically to providers, and where did that leave self-direction kind of in the mix there? Just kind of wanted to know, I guess, if we're trying to treat both sides equally, why maybe self-direction did not get that cost of living adjustment.
Yep, thank you for sharing that. So the reason why the American Rescue Plan Act funding that Maryland got specifically for the developmental disability services, our operated Medicaid waiver programs, legislation was introduced by Maryland advocates that directed the funding associated with the American Rescue Plan Act to be directed towards provider rate increases. So we followed the Maryland law that was passed. I'm going to try to again explain that when those rates were increased, those rates were put into our LTSS Maryland system, for which the person-centered plan is located for both service delivery models. So regardless of service delivery model, when that plan is developed, it will note the services that are being requested based on assessed need. It will include the service units, 15 minutes or hours, it could be a milestone, whatever the unit is, so how many units are needed, and then it's multiplied by the rate. So that rate that was increased is being utilized for both service delivery models, and therefore it is reflected in the current authorized person-centered plan. Thank you, Cody, for sharing your questions today. Eric, do we have another question?
We do. The next person is Jean Daniello. You have 2 minutes for your comment, and we will unmute your mic.
Hello?
Good
Can you
evening.
hear me?
Yes, we can. Thank you for joining us.
Okay. I did miss the first 20 minutes because I didn't get home from work. So I hope I don't repeat anything that anyone else said. But I have been doing self-direction with my daughters for 10 years. So I feel pretty knowledgeable. And over that period of time, the salaries have kept up with inflation somewhat and cost of living. And we have providers that have allowed my daughters to thrive. What you're suggesting is very impractical. You're going to be asking them to take significant pay cuts if this plan goes through. And I'm terrified of losing them. And I want to know, what is DDA's practical plan for these problems? Because I'm not the only one. Where are we going to go with our adult children if we have no staff? The agencies are full, and my daughters did not do well. We were in 3. They're 36. I'm talking about twins. I'm in my 70s. I don't have the energy to continuously fight everything with DDA and beg for services. They need care, but they're out in the community, and like I said, they're thriving. Does DDA have a plan, a plan B for when, if these go into effect, then how are you going to manage all these people who might be harmed? Despite the practice, you explain it. I don't want to hear that because I don't believe in that. It doesn't seem to me that the rate for institutionalization is right either. It costs way more, and I work in a state institution myself. It costs so much more. I don't know how they got that, and I don't want to take any more time. But what's the plan B? Once it goes into effect, then what? Thank you.
Yeah, thank you for joining us. And I'm sorry that you were unable to join us earlier. Fully understand the challenges with getting off work. Please note that last week's webinar, the webinar that we conducted today at noon, the webinar we conducted today at 3 for our Spanish speaking, and tonight's webinar will all be posted on the DDA amendment webpage if anybody would like to go back and hear the presentation or listen to some of the questions from the previous ones. In terms of today, just a reminder, we are talking about the program sustainability requirement that is noted in the DDA budget to establish a $500,000 person-centered plan, authorization budget cap, and also an exception process. Please note that there are additional program sustainability proposals in the DDA budget, which includes looking at self-directed services, reasonable and customary wages by utilizing the Bureau of Labor Statistics and including other considerations such as employer-related expenses. There is also another one that is looking at the wage exception process and ending that. So those are additional program sustainability strategies that are noted within the DDA budget. The budget cap of $500,000 will require a waiver amendment, and that's what we're talking about today and getting input on that. If the other strategies continue to go through with our budget, we will again reach out to self-directed participants and self-directed community to share additional information related to next steps on those. We understand that there are concerns related to potential changes in reasonable and customary wages. And we appreciate everyone's questions and considerations and different points of view related to the cost neutrality calculation. We again have information that's available within the actual currently approved Community Pathways Waiver, which is reviewed and must be approved by the Center for Medicare and Medicaid Services in order for us to continue to operate the programs. And we will continue to follow the Center for Medicare and Medicaid Services requirements related to those calculations. So again, I appreciate your comments and that you're sharing you disagree with our calculations. We will always take those into consideration and appreciate you joining us today. Eric, we can go to the next person.
Our next person is Michelle looks like Shemrick. You have 2 minutes and we will unmute your mic.
Hi, can you hear me?
Yes, good evening, Michelle.
Good evening. My question is more about the exception for the $500,000 cap. I was wondering if removing that $620,000 exception cap and the language regarding discharge is removed, is the assumption that DDA is going to approve services that are demonstrated as appropriately needed, regardless of the dollar amount? And is the assumption that discharge language will not be needed because discharge will not be necessary if providers are properly funded to meet the participants' needs? So it's kind of a two-part question.
Sure, absolutely. Let me share some additional information related to the budget exception process. First, I would say that all person-centered plans that are over $500,000 will automatically be considered for the exception process. In our presentation today, we noted the standards for approval of that budget exception. There is no longer a proposed upper limit on that. So yes, plans can exceed the $500,000 person-centered plan budget cap, provided that they meet the standards. The standards that we shared today is that individuals would have a nursing care plan or behavior support plan with supporting documentation demonstrating the need for enhanced level of supports. The DDA will be conducting additional training specific to the nursing care plan and behavior support plan and supporting documentation. As we noted today and in our slides, a statement or prescription for enhanced supports, overnight supports, or one-to-one or two-to-one services is not sufficient. What we need is we will be looking for specific documentation that explains the specific needs that require additional staffing, the enhanced rate, or overnight supports, what task and support staff will provide, when and why extra staff are needed, and what training or skills staff must have. So to summarize, individuals, regardless of their plan total amount, if they have the documented assessed needs as demonstrated in the plans, the nursing care plan and behavior support plan, and that supporting documentation that is more than just a statement that someone needs one-to-one, but specifies the specific needs, the task and support staff will provide, the when and the why extra staff are needed, and the training, then that would be authorized and the participant will continue to receive services and supports. Thank you again for joining us today. We really appreciate it. Eric, we can go to the next person.
Our next person is Karen Smith. You'll have 2 minutes and we will unmute your mic.
Yes, can you hear me?
Yes, Karen, thank you for asking another question or sharing your comment.
Yes, thank you so much. So with the exception, I know that there will be a lot of documentation that will be needed in order to approve an exception. And many participants already are being told that DDA does not accept supporting documentation from various professionals such as doctors or therapists or other specialists. And the participants have been told that the information cannot be expected, that all supporting documentation must come from a DDA approved nurse and or a DDA certified behavioral provider only. Has this changed? Like, is that a new policy? Or I'm just worried because this is already happening now. And then if we implement the exception, if we implement the $500,000 cap and you need to go through this exception process, can you speak to like what documentations are going to be allowed and permitted?
Yeah, absolutely. As we've shared today and have included in our track change documents for the amendment proposal, supporting documentation should be provided in addition to the nursing care plan and behavior support plan. Additional documentation of the assessed needs may include formal health, communication, or behavioral assessments completed by qualified professionals such as physicians, mental health professionals, behavioral specialists, special educators, and other licensed health professionals as appropriate. Again, we have proposed this additional information can be provided by these types of professionals in our proposal. We've also shared that when sharing additional documentation, that a general statement or prescription by those types of professionals saying that extra staff is needed is not enough. We need more details, and that includes the specific needs that the person have that requires the additional staff, what task and support staff will provide, when and why extra staff are needed, and what training or skills staff must have. The DDA will be conducting additional training specifically related to the nursing care plan and behavior support plan to include information related to the supporting documentation. We look to do that early April to support individuals and participants and providers so that we're all understanding the information that is needed in order for us to authorize those additional supports and what is considered for the assessed need for supporting documentation. We are working to create a guide for nursing support services for the nursing care plan, and we're working to create a guide related to behavior support providers in terms of that behavior support plan. This additional information will help to assist all stakeholders and the DDA to assure that we have the information to be able to authorize those additional services. So again, we've proposed the additional qualified providers. We have shared and proposed additional supporting documentation that we need in our amendment proposal, and we will be conducting additional training to support all stakeholders in knowing and understanding what is needed so that we can continue to support people enrolled in our program, new applicants and families with services and supports they need based on the federal authority that we have with us. Thank you for sharing that with us. Again, more information to come. We look forward to sharing additional guidance and information to support the process. Eric, do we have another person?
Yes, the next person is Bernadette Oline. You have 2 minutes and we will unmute your mic.
Oh, there it is. Can you hear me now?
Yes, thank you, Bernadette.
Oh, finally. Okay, so we just got a clarification for the exception to the PS enhanced, and there was no details as to what they were looking for or why it was rejected. The nursing plan has one-to-one, the behavior plan has one-to-one, there's lots of supporting data. So how do we get more clarification on what they're looking for?
Yeah, absolutely. I would suggest, because it's very difficult to know all the details related to this situation, that you would reach out to the regional office who can provide additional information and support. Please note, as a person-centered system, we would need a release of information if you are not already designated as the legal guardian or representative. We would need a release of information from that. But please reach out to the regional office and so we can further look into that and provide additional information and support related to our clarifications. Please note, when we are reviewing a person-centered plan, we will look for the assessed need and documentation. Our clarifications will share a request for additional information or documentation based on the request we have. We will decision plans if we do not have the supporting documentation based on our information that we have. If we decide, if the determination is a denial, we will also include the rights for participants to appeal our decision. But again, our clarifications are requesting additional information, and you can reach out to the regional office or your coordinator of community services for additional information. Thanks for sharing your question and comment. Eric, do we have another person?
Yes, next person is Cody Stevens. We will unmute your mic and you have 2 minutes.
Are you there?
Yes, hey Cody. Thanks for
Hey.
asking another question or sharing a comment.
Yeah, no, I was just kind of looking for another clarification because I was kind of in the same situation regarding the doctor's prescription versus kind of the extra information. And I know that's going to be discussed later on. Unfortunately, we're kind of in a situation where there's going to be we're collecting information for our review now. And so I wasn't sure, one, who I could talk to possibly directly about that outside of maybe a regional nurse, And then going the other completely different direction. When it comes to the different centers, I was still just trying to figure out the budget neutrality thing. And I know that there's a bunch of information that we can go and research, and you put it out there. I appreciate that. I was trying to understand, and maybe this is a Medicaid question even, but I know you said, when they come out of the facility, I guess, is when they're utilizing state funding versus, I guess, the Medicaid, which is in the building. I just want to make sure that I understand that correctly. Because I don't know, I didn't really realize there was a difference in that, or a way that was kind of measured in that direction. I guess I'm trying to understand that, because I know to some extent that does affect budget neutrality.
Yeah, thank you for sharing that. I think that, Cody, I would suggest, in terms of your first question or comment, please look at our amendment proposal and the additional information that we're requesting related to supporting documentation. It must explain again the needs that require additional staff, what tasks and supports staff would provide, when and why extra staff are needed, and what training or skill staff would need. So I think that will help. You can absolutely reach out to the regional office for additional advice or guidance related to that. Again, just note, we would need a release of information or documentation that we can have those discussions if we're going to talk about specific details. In terms of the cost neutrality questions, again, please note that some individuals, not all individuals, but some individuals may go out during the day and be engaged into other community activities. When they do that, those are not Medicaid services because they're outside the institution. Services that are provided in the institution would be covered under the Medicaid state plan for the state residential center. And those are costs that can be used for the calculation and demonstration of cost neutrality. When some individuals do leave during the day to engage in meaningful activities, they are supported with those activities with 100% state general funds. I believe another question that I just dawned on me that was asked was about the effort in our budget last year to help support and convert state funding participants to Medicaid waiver participants. So we do have individuals that do not reside at Holly Center or Potomac Center that are completely funded with their DDA services that are waiver-like services with state general funds. For those individuals who meet our level of care, we have been working with them to complete the Medicaid waiver application process so that we can maximize our limited dollars to get the federal match. For individuals in the Holly Center and Potomac Center, they are within an institutional Medicaid coverage group, which means their services and supports that can be billed under Medicaid are all associated with that institution. We are not able to claim Medicaid services or cost for any services that they're receiving outside the institution when they engage in these meaningful day activities. It's not permitted, it's not allowed, it cannot be added to the calculation of cost neutrality. So I know as everyone is trying to understand the cost neutrality and the calculations, we have reviewed during the last amendment the CMS guidance. We have reassessed the actual Medicaid cost and then reset the cost neutrality levels based on CMS requirements for actual Medicaid claims for the Holly Center and Potomac Center. Our FAQ, or frequently asked question document, will include additional details related to the different factors that are considered for cost neutrality. Those factors include the number of unduplicated participants, the average annual cost of waiver services for people in the Community Pathways Waiver Program, the average annual cost of other Medicaid services used by waiver participants. That would be like going to the doctors, the pharmacy, and specialists that are Medicaid claim services. And that's compared against the average annual cost of the institutional service costs that would be used if the waiver didn't exist, in addition to the average annual cost of other institutional services, Medicaid actual claims for those services within the institution. So hopefully that is helpful. Hopefully Appendix J will help, and the frequently asked questions as you try to further look into the cost neutrality. Thank you again for sharing your question. Eric, do we have another person?
There are no hands raised at this time. We just got one hand. Jessica Gallatin, you have 2 minutes and we will unmute your mic.
Get it? Can you hear me?
Yes, Jessica.
Oh, thanks. Sorry. Another question after I heard you about denials. I just had a really quick question. I'm curious if participants' plans are denied, typically they become informed of that through their CCS, which I would imagine is communicated through the LTSS system. And oftentimes that information and that notification comes much, much sooner than the official denial letter. I think there's been a lot of questions raised for some individuals about whether or not the window that they have, I think it's either 10 or 15 days to appeal that decision and still receive a stay of services. It's a very small window. Does that begin the moment that they are notified of the denial through their CCS or through the LTSS system, or does that begin when they actually receive an official denial letter? And second, does the official denial letter is where everything is listed regarding next steps for an appeal? So oftentimes when families or participants are told about their denial through their CCS, they're left lingering, concerned about what to do, what their next steps are, where do they go, what should they file, and that stress of, hey, my window is closing because now I've known about this for a week, but I still have no letter in my hand telling me what to do. Can you clarify when that window begins and ends, and how soon, or does it happen simultaneously that the DDA will issue and mail a letter at the same time that they upload the denial in the LTSS system for the coordinators to view?
Sure, absolutely. So when the DDA decisions a plan, they will either approve or deny the plan within the system. When we do that, it creates a letter, an approval letter or denial letter, that is then print out with the additional information such as accessibility information, right to appeal, etc. And that is mailed to the individual. Because we make that decision within the system, once we make that decision, an alert immediately goes to the CCS so that they are aware of that, while the DDA then is creating the letter and mailing the letter. The letter will say the specific information, as you noted, related to any denial and the reasons, the right to appeal, and the process and steps from that. The department has also created a dedicated web page. Medicaid has created a web page specifically to Medicaid fair hearings, where individuals can go online on this web page and actually submit their appeal electronically so that it's immediately captured. We can look to share additional information in a webinar or in our newsletter related to the process and avenues that people have in terms of filing their appeal, so that they are able to choose whether they want to complete the form, fax it in, or utilize the online new option. In addition to being able to submit the appeal online in the Medicaid Fair Hearing webpage, there is also a mobile app that can be used to submit that. So thank you for sharing your question and your comments. But again, once we decision a plan within the LTSS Maryland system, it will immediately send an alert to the Coordinator of Community Services to let them know. We will also issue a formal denial letter that will share the reasons for the denial, including the person's rights to appeal and the process for which to do that. We are in the process of updating that letter to include additional information about the new online appeal option, and we'll look to share additional information in a webinar, a communication, or possibly the DDA newsletter. Thank you again for sharing. Eric, do we have one more?
Yes, her name is Anne Learborn. You have 2 minutes, and we will unmute your mic.
Hi, I'm sorry if my dog decided to go crazy right now. My question is, if the Maryland General Assembly reduces the cuts, will they come back to stakeholders to get input about any changes that will occur to the proposals?
Yeah, great question, Ann. I cannot speak for the Maryland General Assembly in terms of their process and what they may do related to reaching out. We are on the standby and waiting for decisions related to the proposed sustainability in our budget. As we get additional information, we will share, but at this point, I have no updates or information. Thank you for sharing your questions and comment with us. So I know we're coming to our time, and I wanted to again review and share a couple things. We will be conducting 2 additional webinars next week for our Spanish-speaking community. We will continue to share the same information, take questions and comments. We will look at frequently asked comments or questions for today and tonight, and update our frequently asked question document as appropriate for that. Please note that we have added to our website an easy to read summary of the amendment proposal in both English and Spanish. We have also added that frequently asked question document both in English and Spanish. The public comment period is through April 1st. Please send your public comments to the dedicated email address, wfb.dda@maryland.gov, or you can mail it directly to the department at the DDA Federal Programs Unit, 201 West Preston Street, the 4th floor, Baltimore, Maryland. Again, thank you so much for joining us. Wish you a safe and healthy night. Look forward to talking to you again soon. Thank you.